My name is Dean Toriumi. I'm from the Division of Facial Plastic and Reconstructive Surgery, Department of Otolaryngology, Head and Neck Surgery, the University of Illinois at Chicago. I'm discussing the paper entitled The Tip Extension Suture, a new tool tailored for Asian rhinoplasty. In this paper, the authors discuss the treatment of the nasal tip in Asian rhinoplasty. Most Asian patients are in need of augmentation and many require tip elongation or counter-rotation of the nasal tip. Asian patients have less septal cartilage than Caucasian patients, and their septal cartilage is weak compared to most Caucasian patients. This creates a dilemma when augmentation is necessary. In this paper, the authors describe their technique of the tip extension suture. In their technique, they release the lateral crus from the sesamoid cartilages in the hinge area to allow caudal advancement of the nasal tip. They place 2 to 3 5/0 nylon sutures along the cephalic margin of the lateral crus. The tip structure is fixed to the caudal septum using the same sutures. The sutures advance the nasal tip caudally to counter-rotate and elongate the nasal tip. This suture is similar to the lateral crural spanning suture previously described by Tevitz. The suture may require the addition of a columellar strut or dorsal batten graft to create adequate support and stability. In the paper, the authors presented their experience using the tip extension suture. They used this technique in 283 patients between May of 2008 and December of 2011. The mean follow-up was 14.2 months with a range of 6 to 26 months. The authors showed excellent patient satisfaction in 92% of the patients with a minimum of 6 months follow-up. There were 159 patients, or 56.2%, that were satisfied. 102, or 36%, that were very satisfied. 10 patients, or 2.9%, were unsatisfied. 14 patients, or 4.9%, experienced a recurrence of their preoperative deformity. The authors reported 8 patients that suffered a pinched tip deformity. This deformity likely refers to alar retraction creating an isolated tip. If you look at their diagram showing the tip extension suture, it spans the cephalic margin of both lateral crura and also catches the caudal septum. This suture is very similar to the lateral crural spanning suture described by Tevitz. The lateral crural spanning suture is helpful in managing the bulbous nasal tip. One of the deficiencies of the lateral crural spanning suture is that it can cause alar retraction, as it can create cephalic positioning of the lateral crura. In Dr. Kim's paper, he appears to describe this complication as the pinched tip deformity, which did occur in 8 patients. He showed 2 examples of the pinched tip deformity. This type of deformity is less likely in Asian patients as their skin is thicker and the alar lobule and alar margin is less likely to be affected by the suture techniques because of the thicker and more resistant skin envelope. However, with time, it's possible that the incidence of the pinched tip deformity could increase. The authors discussed using acellular dermal matrix, or alar spreader grafts, for correcting the pinched nasal tip. It is unclear whether the acellular dermis is used for structural support or for closing mucosal defects created due to inadequate intranasal mucosa. This could be created after the nasal tip is lengthened. In either case, acellular dermis may not be the best option for such deficiencies. A deficiency in lateral wall support could also be corrected using alar batten grafts or lateral crural strut grafts. A deficiency in intranasal mucosa could be corrected using a composite skin cartilage graft harvested from the ear. The authors state that one of the major advantages of the tip extension suture used for tip elongation is that it does not require additional cartilage commonly used in grafting techniques. They state that this is particularly important in the Asian patient as they typically have limited amounts of harvestable cartilage. Avoiding the need for extra cartilage eliminates the need to go to a secondary site to harvest cartilage for grafting. In the Asian patient, my philosophy is that these patients require augmentation. I tell them that in order for me to provide a long-term aesthetic and functional outcome, I typically will harvest cartilage from another location. I choose not to use alloplastic implants in the nose, so this increases the need for grafting material for the nasal dorsum. My preference is to harvest the 6th rib via a 10 or 12 millimeter incision underneath the right breast. This technique leaves the patient with little scarring and minimal postoperative pain. Drawbacks to using costal cartilage include longer surgical time, potential cartilage warping, donor site morbidity, and increased stiffness to the nose. I discuss these issues with the patient preoperatively and also emphasize the importance of long-term postoperative follow-up. My preference for correcting the short, over-rotated nasal tip is the use of a caudal septal extension graft and repositioning of the lateral crura with lateral crow strut grafts. The caudal septal extension graft is placed end-to-end and is typically stabilized using extended spreader grafts. Once the nasal tip is counter-rotated, the lateral crura can be repositioned by dissecting them off of the underlying vestibular skin and placing lateral crow strut grafts as described by Jack Gunter. Then the lateral crura are repositioned caudally into caudally positioned pockets along the lateral wall of the nose. I have found this combination of techniques to work well in elongating the nose in the Asian patient. Another problem with the tip extension suture technique is that the lateral crura are released from the lateral-most connection to the soft tissues. Cartilage is not added to the dissected lateral crura to increase lateral wall support. It is possible that there may be some lateral wall weakness that occurs over time as the lateral wall support has been weakened. In conclusion, I believe the tip extension suture technique is a very good option in Asian patients, particularly if they require tip elongation and want to avoid going to a secondary site for cartilage harvest. This may be a common scenario in Asia, as many of these patients do not want to undergo involved surgeries. I believe that there is a place for this technique, but it must be used cautiously to avoid alar retraction or the pinch tip deformity. The same goes for using costal cartilage in Asian patients, as this must be done cautiously to avoid warping or deformity. Thank you.